we have the next session, which is always an interesting one, which is a research update. So that's when we ask a senior researcher to have a look at what's happened, say, in the last year or so, and select what they think to be particularly interesting, important, or maybe entertaining types of results that have been found in the last year. Today, it's my pleasure to introduce Associate Professor Daina Sturnieks, who's going to be doing this job today. So Daina is based at the University of New South Wales and Neura. She originally started in biomechanics, but over many years now has been working in all aspects of falls prevention, from risk factor studies to interventions and also implementation work. So she's very well suited to give the talk today on a research update. So welcome, Daina.
Thank you, everyone. Yeah, the research update. So I went trawling through all the papers and tried to find the most impactful and interesting for you. Let's get started. I'm breaking this up into understanding fall risk, then interventions, which we have a lot of, and then some touching on implementation at the end. So let's start with understanding fall risk. And a lot of work was done over the past 40 years looking at risk factors for falls. And as a result of all this work, there are now multiple reviews reviewing the risk factors for falls. And this is a review of a review. So an umbrella review, a review of the reviews. And it examined, so the reviews were published between 2004, 2023, and there's 57 reviews of falls risk factors. So it tells us we've got a lot of knowledge on what the risk factors for falls are. And the majority involve studies that were done in high-income countries. We must keep that in mind. And I was surprised there was only 29 risk factors that were summarised in this review of the reviews. Now, this doesn't perfectly represent it because it's just the meta-analyses that were done on various risk factors. But it turns out that the majority of the risk factors were mobility related. So they accounted for 40% of all the relationships discussed in this review. You can see frailty here. You see in blue the number of reviews that had a significant relationship to falls, and then anything in grey and insignificant. So uncontroversial that frailty is a risk factor for falls. Then you can look at chronic conditions where there are some, so about 10 significant reviews and about 5 or so that showed insignificant findings in terms of the association with falls. And then the next one's balance, so just one review that had contradictory findings. Anyhow, there's a paucity of evidence on the psychosocial, environmental and socio-demographic factors. Most reviews were rated as low risk of bias. This is encouraging. So that's summarising what we know about risk factors. And I guess there was a lot of work done in healthy populations way back in the 80s and the 90s, and now the types of studies that we're seeing are in particular clinical groups. So here's one I found on people who were deemed to be pre-frail. So this is, again, a system. I'm an evidence nerd, and so I love it when someone else has done the work to summarise the evidence so that I can understand it and, of course, present to you. So there's a lot of reviews and systematic reviews here. This is a systematic review of risk factors for falls in older people with pre-frailty. 26 studies, moderate to high quality papers, and identified 16 potential risk factors. And you can see here the weighting or the odds. 3 times more likely to have falls if the person has peripheral neuropathy. So you can see that as the strongest risk factor, and just cast your eyes over the other ones there. So that's in a pre-frail population where they scored 1 or 2 on a 5-point frailty index. So they're not deemed to be frail. Another review looking at people with diabetes. And this review involved 32 studies, over 23,000 participants, and this study showed that this population, people with diabetes living in the community, 30% of them are having a fall. Now that sounds sort of similar to what we hear in non-diabetic or what we might consider healthy populations, but it is at the upper end of those healthier individuals. So they did suggest that people with diabetes do have an increased risk of falls, and here are the risk factors in that particular group. Obviously, poor control of the diabetes, so hypoglycemia, double the risk, depression, neuropathy, as a result of the diabetes, which possibly contributes to gait problems. So there we can see some other risk factors that are identified in this diabetic group, but I think it's important to note those more significant or risk factors with the higher odds ratios, just to be keeping in mind when you are working with people with diabetes. So moving swiftly on to interventions, and there's a lot to talk about in this in the intervention space. First of all, Cochrane review, our best level of evidence we have for interventions, and we used to have a review looking at, our older review was interventions for falls in older people in care facilities and hospitals, but now they've been split up, and this is the updated review just in care facilities, authored primarily by Sue Dyer. 104 studies, over nearly 69,000 participants. You can see the average age is 84 and 72% women. So what they found was that multifactorial interventions probably reduce the number of falls, so that's the number of falls that was the number of fallers, so the proportion of people reporting a fall, but not the rate of falls, so not the number of falls reported. And there are larger effects of multifactorial interventions when put in place with facility staff and they're individualised. So the multifactorial interventions are interventions that had multiple components to them, but they are based on an individual's risk profile. Exercise probably reduces the number of fallers and the rate of falls in care facilities. Now, it's interesting that Sue identified that this is the case when we look at the endpoint for that exercise, but the exercise needs to be ongoing if you're going to have the effect on falls to be significant. So the effect of exercise drops away quickly at the end of the exercise program. So that was an important finding. Medication optimisation as a single intervention seemed to have little or no difference to the number of fallers or the rate of falls. Vitamin D supplementation probably reduces the rate of falls, the number, so thinking about the recurrent fallers. And then, of course, one trial told us that dairy foods, dietitian assistance with the menu design can decrease the risk of falling and fractures in older people living in care facilities. So this was the previous Cochrane review that we had information about the hospital setting, but thankfully it's just recently been updated and it's not yet published. So thanks to Charlotte McLennan, who led this work, who has shared her results with us today. Should be coming out this year, I think. It's imminent. Good. In the next month, so keep your eyes peeled. 55 trials, and there are 32 new trials compared to the previous review, which was, I think, 2019. So obviously doing much more work in this area. Over 100,000 studies. Sorry, that's probably participants, I think. 55 trials, 100,000 participants. And mostly low certainty evidence. But Charlotte has just highlighted what we did have some level of certainty about the evidence, and there's quite a bit here, so I'm going to have to turn around because it's very small over here. Exercise may reduce the risk of falling in the subacute setting, so little to no effect in the acute setting, which makes sense when people are in this acute setting and have less time in that setting perhaps, and also are quite sick. Medication optimisation, there's uncertain effects in the hospital. And I think this morning we did touch on the fact that medication optimisation does need to be done in combination with other interventions. Service model change, so that's looking at changes in the model of care or the organisational system, with falls as the priority, probably reduces the rate of falls in acute settings. Education, whether it be patient, staff or multi-component, probably reduces the rate and risk of falling, but in cognitively intact populations, uncertain in those with cognitive impairment. Environment and assistive technology, the effects are uncertain in terms of low beds, and there's no strong evidence for other approaches, so they looked at other sort of technologies and environmental sort of aids, I guess, in the hospital setting. And then multifactorial interventions, we talked about that in the aged care setting, obviously based on the individual's fall risk, probably reduces the rate and the risk of falls in the hospital. So there's good evidence for that. And then multiple interventions. So that means it's different from multifactorial interventions in that there's multiple parts to the intervention, but they aren't tailored to the individual. It's like a package that's offered. May reduce the risk of falls in older people in hospitals. Okay, so that's, the upcoming Cochrane review that we'll all be looking out for and waiting to read the full version of that, or you could just refer back to this summary slide. Okay, so now looking at some individual studies. This one, which was published and led by Lindy Clemson, which was a home-based tailored intervention to reduce falls in people who have had a stroke. And you can see that it was a relatively large trial with 370 participants. They were recruited within 5 years of having had the stroke. They were at least 50 years of age and living in the community and able to walk 10 metres at least. It was a 6-month intervention, and it was delivered by an OT and a physio in combination, so one of each, and it included 3 components: a habit-forming functional exercise program, which was essentially the LIFE program, which many of you might be familiar with. So the exercises are embedded into daily routines. A home fall hazard reduction, so like an occupational therapist assessment and review of the home setting. And then goal-directed community mobility coaching, so setting goals about mobilising safely in the community. And though these interventions were delivered over 10 home visits from the OT and physiotherapist, and in terms of how that went, there's an adherence score of 15 out of 24 for the exercise, for the LIFE program exercise, which is not too bad. 77% implemented at least half the recommendations for the home fall hazard reduction after the assessment. And then nearly 80% had set community mobility goals. So that tells us a little bit about compliance with the intervention. And in terms of the results, at 12 months, there was a 33% reduction in falls in the intervention group relative to the control. There was no significant reduction in the number of, or the proportion of fallers in the intervention group compared to the control group. So that's the FAST trial for stroke, a nice reduction in falls. This is another nice study I discovered, which was actually developed as an intervention to improve cognitive performance in people with mild cognitive impairment. But they published this paper on their secondary outcomes, and those outcomes were gait and falls, gait performance and falls. So it was a complex trial design, but I really like these. They're called a factorial design, where they've got multiple elements to the intervention, and each group has either all of them or one element, and then sham in the other couple of elements, and then the control group has none of those. So hopefully you can read this. This group here had all the active ingredients of the intervention: exercise, so physical exercise. It was resistance aerobic training based on guidelines, cognitive training, and vitamin D. And then you can see the next group along didn't get the vitamin D, they got a placebo, and the next group along got the sham cognitive training. So it's a really nice, neat design to understand the effects of multiple elements to your intervention. And I think there was 35 or so participants in each arm. So it was 20-week intervention of this exercise, aerobic resistance exercise, cognitive training, and with or without vitamin D supplementation in people with mild cognitive impairment. It was multi-site, randomised, double-blind, fractional factorial trial, all the good things. There was 161 participants, and the primary analysis of the cognitive performance did show that the addition of cognitive training to the aerobic resistance exercise significantly improved cognition, but vitamin D had no effect. Now, these secondary outcomes, the 4 exercise-based arms improved gait speed and reduced falls and injurious falls at 6 months and falls at 12 months. So the intervention went for 6 months. They looked at those outcomes both at 6 months and then again at 12 months. Now, the exercise combined with cognitive training showed the greatest gains in gait speed at 6 months and in falls at 12 months compared to the control group. And they found that vitamin D did not enhance the outcomes, so obviously in the cognitive outcomes, but also these physical outcomes too. So, exercise reduced falls by 35%, and I'm not getting the clicker to go on. Thank you. The exercise and cognition was an even greater effect, and here you have a graph just showing you the effects of 3 of those groups in a habitual gait score. So here's baseline, here's 6 months, and here is the mean change in habitual gait. So this is obviously better, and this is worse. Here's all 3 active ingredients to the intervention, just vitamin D and exercise, and then the control arm got worse. So I like that study. A nice example of a complex intervention, but done well. Okay, this work comes from our Neuroscience Research Australia, our research group there, and Shivam Sharma has led this systematic review of interventions that train reactive balance, so perturbation-based balance training, and their effects on falls and falls injuries in older people. So here's the forest plot. Hopefully you're semi-familiar with this, but here is the line of no effect. Here are the studies that were included in this meta-analysis, and you can see it's been divided into those studies involving high-risk populations and healthy populations, and you can see that the variability amongst those studies and the average effect. So we can see that his results show that taken together, so all of the studies, we see a significant beneficial effect of perturbation-based training in terms of falls. And you can see that that's driven largely by this healthier group, more so than the high fall risk group, which I can tell you is a challenge to implement this type of intervention. Here is the types of interventions that might have been included: treadmill-based perturbation training, overground walking type of perturbations, so trips or leg pulls, and then the manual sort of push-pull type of intervention. So it was a mixture of those. So here, this forest plot now breaks it up into those 3 types of intervention approaches. Overground walkway, just one trial, it was successful. The treadmill, a bit more variable, and then the standing manual also a little bit more variable. So this particular study is driving this good result in terms of the effects of perturbation training on falls. And then finally, another thing that I thought might be interesting is to understand the dose. So the value of perturbation-based training is not only that it challenges a different element of balance, reactive balance, so that's a good thing, but it's also very low dose. We get effects very quickly, and so we can offer it with much lower doses than traditional exercise. So let's have a look at the dose the dose information. Higher dose, obviously, we get much better effects. So the cutoff was 6 hours, so still over a 6 to 12 month period, that's very low dose as you can appreciate. And then, a non-significant result for those programs that were under 6 hours. So really nice work to better understand whether perturbation-based balance training can prevent falls in older people. Okay, so just touching quickly on implementation of fall prevention strategies. There was a really nice paper that was published by Melanie Haley, Falling Short on Implementation of Fall Prevention Guidelines in Health Services. So again, another systematic review and meta-analysis, 55 studies, over 100,000 patients. They identified 14 fall prevention guidelines that were evaluated in these studies, but found that the methodological quality of those studies was largely poor, and basically found that the median reach of the guideline implementation was reasonable, 64%. No suggestion that the implementation of these guidelines did prevent falls, and that there was some suggestion that the adoption of the fall prevention recommendations by health professionals did improve, so there was some progress made there, and a very wide range of adherence to the recommendations to the patients. So it did suggest, indeed, that we are falling short on implementation, because we do understand, I've shown you some extra examples today of strategies that we know can prevent falls in older people in clinical groups, but the challenge now is making sure that we implement those appropriately, and we really need these sort of high-level approaches to make sure we do that well. I just need the cursor to move across again. Thank you. And so, yes, one particular paper highlights this need for doing more of this implementation evaluation, because a systematic review that identified 4 papers with only 3 studies, 2/3 of them were stepping on program, basically did tell us that systematic implementation of strategies to train or educate stakeholders can improve the number of fall prevention interventions hosted by countries or communities, but there's a significant gap in this research around the effectiveness. And so we do need to do more to better understand how to implement interventions well for successfully achieving a fall prevention benefit. And the work that was done in WA, I was encouraged by that talk by Rasheen this morning, because it does tell us that there is some fantastic work that we could be doing. We need to do it, we need to do it well, we need to evaluate it, and hopefully we'll do well to prevent falls into the future. Thank you very much.